Okay, we're back. I just wanted to reiterate, this will be the fourth recording to try to get through this infant feeding lesson. With the study that was done in Africa, the two reports, again, exclusive breastfeeding for the first 3 to 6 months after birth by HIV-infected mothers did not increase the risk of HIV transmission to the infant, whereas the infants who received the mixed feeding, they got the breast milk with the formula, had a higher, much higher, 50% higher rate of HIV infection compared with infants exclusively breastfed. So if that's not an indicator or evidence that breast milk is the good stuff, I don't know what is. That's just crazy. Now, women in the United States, I want to say that are HIV infected, they do not breastfeed. They say it's contraindicated here because we have other things. So just to make that clear. So here are conditions that are not. So you might want to circle or underline that not. I should have bolded it. But these all are conditions that are not contraindications to breastfeeding. Women who are HB positive, infected with Hep C virus, who are febrile, mothers who have been exposed to low level environmental chemical agents, and that could be any type of radiation. Mothers who are seropositive carriers of CMV, not recent converters if the infant's term. Mothers who smoke, we don't think it's a good thing, and they shouldn't smoke around the baby, but we're not going to say that they can't breastfeed. Always avoid using alcohol. And what we usually tell them, too, is if you're going to go out, that you can pump and dump. That's what we say that we want women to do, is to dump it. If you drink alcohol, say you're out for some special occasion, and say you're out at 8 o'clock at night, and you have an alcohol beverage, and you're done by 9. They say when you get home, you're going to dump that first feeding. You're not going to give the baby any any milk with the residue of alcohol in it. And then majority of high bilirubin newborns, we used to not give them breast milk because they wanted to push that bilirubin out the stool. So we would give them all kinds of water and formula. And then they decided, no, this is ridiculous. Why are we not giving them formula? Listen to me. Why are we not giving them strictly breast milk when we know how good the breast milk is? So, express breast milk care and storage. We're going to always wash hands. We know that. We teach that for everything. Wash hands before and after expression. Wipe nipples with cotton and wash with plain water. No soap at all. That can crack and make them bleed. Water itself isn't astringent, but we know soap is. It's very drying. Wash the breast pumps parts with hot soapy water after each use because they can get mold growing in them also. So we need to wash the breast pump if they are going to work and they're pumping while they're gone. Breast milk can be refrigerated up to 5 days. They've been all over the board on this. But the latest finding from Mayo Clinic in 2015 was that it can be refrigerated up to 5 days. Frozen milk can be stored up to a year, but you have to date and time it, so we know that. Optimal use by 6 months. Once thawed, frozen milk needs to be used within 24 hours, and we even do that in the NICU. We actually use it right away. We take out the packet, we let it warm so that we can give it to the baby, and then we use it all and we dump it. We don't put it back. But if it's your own, you could probably put it back in the refrigerator, but within 24 hours you have to use it. And freshly expressed breast milk can stay at room temperature for 4 hours. I would be very cautious in telling people that in California because it gets so hot here, and we don't know if it in room temperature, what is that? If it's 80 degrees in the house, it's probably not a good idea because remember, it's got all kinds of great nutrients in there. It's a great media for bacteria. So I would usually give it to the baby and make sure it's all gone. And if somebody's watching your kid, I would say that. I would not have them keep it unless they put it in the refrigerator right away. I would not leave it out. Formula feeding. I have a tough time with this one because I'm so passionate about breastfeeding. But we cannot be judgmental. There are people that are just totally against it. I think if we come at them with the right amount of education, I think that they will do it. I heard an OBGYN once say if they are healthy enough to sustain and have a baby, be pregnant and have a baby, they can breastfeed. That it's the normal process that follows giving birth. Because a lot of women will say, I can't, I just didn't have enough milk. And if they needed help, there was something wrong with either the latch or maybe the timing of, or maybe there was a lot of stress and anxiety going on in their life. But the women that cannot or choose not to, we need to not be judgmental in A1. And they actually has updated that to 2012. We're going to select the appropriate formula according to whatever they want. A lot of them that are going to formula feed usually know which one they want when they come in. Assess for patient access to clean water and refrigeration. Again, formula has to be refrigerated also. Discuss formula preparation and storage. It's always on the back of the formula bottles or powder, depending on what they're going to use. Proper positioning for bottle feeding. We're not going to tell them to prop that bottle. That can cause a lot of problems. Aspiration, lack of bonding with the mom. They need to hold the baby to give them the bottle, or somebody does. Grandma, aunt, the dad. And there it is. Reinforce importance of not propping, especially with the teenage mommies. Not that there's some teenage moms that are very, very mature. I'm not saying if you're teenage you can't do it right. I'm just saying that we've got to be cognizant of the fact that it's just not, they can aspirate. Okay, we can't talk about this without talking about hyperbili. We know what that is. It's too much bilirubin in the blood. And it has to do, you guys, with accepted levels at a given age. If you're ever calling on a bilirubin level, the doctor wants to know, how old is this baby? We know bilirubin is an excrement that can cross the blood-brain barrier and cause damage. Encephalopathy, hyperbilirubinemia, and kernicterus. Encephalopathy and kernicterus are interchangeably used. Kernicterus is the term given for encephalopathy due to bilirubin. Affects 60 to 70% of newborns, leading cause of hospital readmission during the first 2 weeks of life. So we have to teach that. They have to know, what they're looking at. Bilirubin is the end product of hemoglobin breakdown. Destruction of 1 gram of hemoglobin yields about 35 milligrams of bilirubin. It binds to albumin for transport to the liver and excretion. And that's where we have unconjugated bilirubin become conjugated and is excreted out through the GI tract. And I just said this. Occurs in the liver. You guys can go ahead and read that. Conjugation must occur in this matter for bilirubin to be metabolized. Physiologic jaundice is the rise and fall of serum bilirubin. It's indirect, and serum means the blood. Level between 6 to 12 milligrams per dl that usually resolves by the end of the first week of life. Very, very common, as you can see, 60 to 70% of term infants and about 80% of preterm infants, because they're just more susceptible to everything. Breastfeeding jaundice is related to consequences of ineffective breastfeeding. So they're not getting enough of that fore milk in the front with the water in it. More common among first-time mothers and preterm infants who receive supplementation. And so, again, with teaching, this probably will not happen. Breast milk jaundice is very much more of a later onset, and you can see begins after 3 to 5 days, so they're going to be at home. Results in an increase in that serum bilirubin that peaks at 5 to 10 milligrams by about age of 2 weeks. May persist over weeks to months of life. Only 2 to 4% of breastfeeding infants develop this. So, again, we have to teach. If they see yellow on the nose, when you press down the nose and it blanches, it should blanch white to pink or white to the ethnic color. If it blanches yellow, if they have yellow in the eyes, they see yellow anywhere else, they need to bring that baby in. It can be very, very serious. Pathologic jaundice is the one that the one that can really hurt the baby quickly. Jaundice is usually in the first day to 36 hours of life. It's increased bilirubin of greater than 0.2 milligrams per dl per hour. I'm not going to have you memorize any numbers. Just know if they're born with a bilirubin of Over 6, we get a little excited because we know it's going to go up. So usually we want it under 6. But then by the second or third day of life, they may be at 10 or 11, but they're still hours old. Now, if they're at 15 or 16 at the second or third day, they need to be under lights. Usually they say if the bilirubin level is at 20 or above, over 20, it can cause brain damage. So we don't like to discharge a baby if they're in the teens anywhere because we don't know which way it's going to go. So if I have a baby that's maybe at, say they're 2 days old and they're at 13 or 14, I'm going to ask the doctor before the baby goes, can we do another bilirubin level? Sometimes they'll say yes, just to see which way it's going. And so say it's at 14 in the morning, we draw it in the afternoon or later in the day, and now it's at 12. Well, that's telling us his liver's kicking in, it's going the right way. If it's over 14, now it's at 16, that warrants, that baby needs, it needs to be under the lights because those lights will break down the bilirubin and help get it excreted. So these were revised in 2012, and these are clinical practice guidelines that promote and support successful breastfeeding, establish protocols for identification and evaluation of hyperbiliry, measure total serum bilirubin or transcutaneous bilirubin on infants jaundiced within the first 24 hours of life. And now they're doing it on every baby. I'm sure a lot of you have seen this, where they scan the forehead and they do 3 checks just to see where the level falls on that graph in hours. And they're trying to see if indeed the bilirubin is going too high. And then they'll draw a serum. They'll draw the blood after they do the TCB. And we have to recognize that visual estimation of jaundice can lead to errors, which means we can't just eyeball it. So again, if the mothers, if we're teaching them, they see jaundice in the face or the eyes, they need to come in and have the blood drawn. And we used to just eyeball it, but now we measure the total serum, either TSB or called TCB. Transcutaneous means across the skin, across the forehead. We measure the amount of bilirubin. I'm sure a lot of you have seen that already. Interpret all bilirubin levels according to the infant's age in hours. I can't stress that enough, because in the beginning, if they're high, we're just assuming that they're going to go higher, because we know that it's going to take a little bit for that liver to kick in and be a part of the whole process of breaking this down. We also need to recognize that infants less than 38 weeks of gestation are at a higher risk of developing hyperbiliry and require closer surveillance and monitoring. The younger the baby, the more immature all of the organs are. That's the only reason why. So you don't have to memorize that, just understand the concept. Perform systemic assessments before discharge for the risk of hyperbiliry, meaning we're going to scan it with that transcutaneous bolometer and chart it in hours. And provide parents with written and verbal instructions about jaundice so that they understand it. We don't want to send them away without understanding. Okay, we're almost done. I need to finish it with one more, so I'll be back in just a minute.